100 kilogram, you can dose it at 1.5 milligrams once daily, which means there will be one injection a day, not two injections. So this is a new interesting recommendation to remember about, and offer the patient the two options and have them decline the injection and go for second-line treatment when we have found the best thing for them. For PEs, thrombolytic therapy only if they are hemodynamically unstable, dropping blood pressure with increasing heart rate, but if they are hemodynamically stable, no need to thrombolyze them. Isolated DVT. So increasingly people look at DVTs and they'll always ask the question, is it above the knee or below the knee? And there's a suggestion that if people have isolated distal below the knee, you may not need to treat them. The risk of bleeding from what you put in them on is higher than the risk that the clot will grow and embolize. So they actually recommend that you may want to hold off on anticoagulation for DVTs below the knee and follow with ultrasound at about 2 weeks or thereafter. Unless if the patient insists and says, I really want to take anticoagulation. But just know that societies with expertise in this are saying we do not think the benefit of anticoagulation here outweighs, it is the risk of bleeding outweighs the benefits of anticoagulation. And I just mentioned about home treatment for low-risk PEs, hemodynamically stable. You can do Clexane once a day in people who are not big, and they can go home. I still get surprised when we admit patients with low-risk PEs who have hemodynamically stable or DVT, because you can give them a 2-week or 10-day supply of Clexane and send them back to that clinic. The local nurse can help with the injection if they have problems injecting, whilst the warfarin is kicking in and getting therapeutic. So the only reason for admission is if you think they are high risk and you are monitoring them for hemodynamic compromise and the need for possible thrombolytic therapy. If you're not thinking they may need thrombolytics, then there's really, and I do that in my practice, a lot of my patients that I see privately with DVTs, if they don't have tachycardia, no shortness of breath, no chest pain, and I have no other reason to think they have PE, or if I do, I get a CTPA and it comes back with minimal disease or nothing, I give them a prescription of 2 weeks Clexane and warfarin and they just at home. So I borrowed this from a lecturer in the UK who said, significant learning feels difficult. Signs of effort, not failure. Effort for learning changes the brain, making new connections and increasing your capability. So let's not be barriers to change and resist the change. I know we have strongly held ideas from our training and our wonderful degrees and our practice, but let us give our patients interventions that are considered more modern, backed by very good evidence.